Okay, good evening. So today's quiz was about LIDS, LACRIMAL and SCLERA. So a mixture of questions from these three topics. So let's see the questions. So the first question was actually an image-based question. A question which was earlier asked. So this was the image given to you. But unfortunately or fortunately for you, I had not asked what is a diagnosis. So the question asked about what is the congenital anomaly of which embryological layer. That was a question. So this is the image based question. But the question was not straightforward. The question was not about the diagnosis. The question was about this particular image. The clinical condition is a defect or a congenital anomaly of which embryological tissue, yes, or layer. So first let's start with what is a diagnosis. This is ankyloblephron. Yes, you see a skin tag or a adhesion between the two lid margins. Can you see that? Yes, so this is a newborn baby, a 4-day-old baby actually. So this is ankyloblephron. So ankyloblephron is a skin tag or a skin adhesion between the lid margins. So this is because of surface ectodermal defect. Now what happens, you know that the lids develop from surface ectoderm. Now there are two lid plates, okay, the upper lid skin lid plate and the lower lid plate, which develop somewhere around close to the 9th week of gestation, okay, 9th week of gestation. And then what happens is in the 5th week both of them close, okay, they zip together. And 5th month they zip together, and 7th month they unzip. So this unzipping, if there is any problem, so failure of separation of this lid plates, yes, that results in ankyloblephron. So this is basically a surface ectodermal defect, okay. So question number 1, many of you 50% have done it right, okay. Now next again is an image based question. So it basically asks what is the stain that is used. Yeah, so you can see the bulbar conjunctiva being stained with a green color dye. No filter has been used. So what is this dye? You don't even need options for this. This is lissamine green dye, because fluorescein will not dye the conjunctiva. Fluorescein basically it fills epithelial defects on the cornea. So this lissamine green dye is a vital, it stains the dead epithelial cells, okay. So dead epithelial cells in the conjunctiva, which happens in dry eye. So this is a typical dry eye diagnosis, okay. The bulbar conjunctiva, when you have dry eye, goes and stains. So the answer is, so the options were fluorescein dye, rose bengal dye, lissamine dye and brilliant blue green. Now some of you were tempted to mark brilliant blue green. See, brilliant blue green we use in vitreoretinal surgeries to stain the epiretinal membrane during the peeling. This is lissamine green, okay, and it's not fluorescein. Fluorescein means you need a cobalt blue dye, and the dye itself will be orange. In the absence of the cobalt blue light, it will look orange, fluorescein. This is lissamine green, okay. Alright, so those of you who joined in late, you can watch the video again, but again for your convenience. So this is ankyloblephron, the skin tag or the adhesion skin adhesion between the two lid margins. So there's a bilateral one, and it is a congenital defect of anomaly involving the surface ectodermal tissue, okay. Now question number 3, accessory lacrimal glands. So easy. Accessory lacrimal glands are your gland of Cross and gland of Wolfram. Now what are the, so there is an option both A and B, and some of you have marked gland of Henle. See, gland of Henle is basically, there are some depressions in the conjunctiva, more near the fonus, okay, the palpebral conjunctiva and more near the phonesis. So these are depressions on the conjunctiva, that is crypts of Henle containing the glands of Henle, okay. Crypts means, so those depressions containing the glands of Henle which secrete mucin, the innermost layer of the conjunctiva. Accessory lacrimal glands are responsible for the middle watery layer, no? Oh, today is, thank God it's Friday. So people are all in vacation mode, huh? Weekend mode. All right. Most common cause of keratoconjunctivitis sicca. So options: sarcoidosis, no. Rheumatoid arthritis, yes. Let's see if there's a better option. Tuberculosis, no. Dacryoadenitis, no. What do I mean by a better option? Although I've said rheumatoid arthritis is the answer. See, if you have an option called Sjogren's syndrome, go for Sjogren's syndrome, because Sjogren's syndrome is the most common cause of dry eye or KCS, keratoconjunctivitis sicca. Now, the most common type of Sjogren's is secondary Sjogren's, and the most common cause of secondary Sjogren's is rheumatoid arthritis. So, indirectly rheumatoid arthritis. Yeah. So, if you have Sjogren's syndrome, that also is right. Okay. Question number 5, the innermost layer of sclera. Guys, what is this? Yeah, so easy, no? How can you mark Brooks membrane? Brooks membrane is the innermost layer of choroid. मेरा दिल टूट गया है इसको देख के. How can you mark Brooks membrane? Brooks membrane, please put it in your brain box. Brooks membrane is the innermost layer of choroid. I am asking innermost layer of sclera, and some of you who marked Henle's layer. Henle's layer is the outer plexiform layer of retina. The other name for OPL in the macula, posterior pole, is Henle's layer. Lamina fusca, that is the answer. Okay, lamina fusca. All the Tamil students remember your Cusca and the fusca. Okay, the Cusca rice that you eat. Schwalbe's line. Yeah, how Schwalbe's line? Man, just now we finished cornea quiz. Cornea, the decimus membrane termination of the limbus is Schwalbe's line or Schwalbe's ring. Bacha kya bacha? What is this? But anyway, those of you who marked lamina fusca, I'm so happy for you. Love you guys. Okay, the thinnest part of the sclera. Thinnest part of the sclera, very, very important. Option A, posterior pole. Posterior. Option B, around optic nerve. Oh, there was a typo there. But anyway, around optic nerve, it's the thickest. Lamina cribrosa, it's thin. Lamina cribrosa area, it is thinner. It's not the thinnest, but it is thin. Behind recti insertion, just behind your recti insertion is where your sclera is thinnest. Okay, just behind, because once upon a time, they used to love this question. Love this question means love this question. Yes. Can you parcel what? Okay. Sloughing corneal ulcer may result in option A, equatorial staphyloma, ciliary staphyloma, anterior staphyloma, posterior staphyloma. But just see, when you have an sloughing corneal ulcer, it's involving the cornea. Okay, so either it should be anterior staphyloma or intercalary staphyloma. Intercalary staphyloma would be for a peripheral sloughing corneal ulcer. Without any particular mention about peripheral corneal ulcer, they're just saying a sloughing corneal ulcer to result in anterior staphyloma. Yes, anterior staphyloma is when your cornea is bulging and the iris is lining it. Because equator is way beyond, no? It's 14 millimeter from the limbus, it's way behind. Ciliary staphyloma, again, ciliary region is 4.5 millimeter from the limbus. So anywhere beyond 2 millimeter from limbus is where you start defining the ciliary staphyloma area. Yes. Very good, Kundan. Yes, around the it's not around the rectus muscle, not even around, just behind. वो जो insertion है ना, insertion के just पीछे. मतलब you have to actually lift it and see it beneath it. Yeah. If you're suspecting scleral rupture, so that is why it is important. It is not because the examiner loves it, because the examiner loves those kind of points. No, because when you're suspecting scleral rupture, you always go, when you're doing the exploration, no, explorative surgery, you always lift up all the 4 recti and just उसके नीचे देखो, उसके पीछे, उसके नीचे और पीछे देखो. Okay, just behind the insertion of recti, you have to look if there is any scleral rupture. Okay. Now, question number 8 appears to be long. Let's see what it is. A patient presents with decreased vision, which I have not told us. Anyway, कोई फर्क नहीं पड़ता. Anyway, on examination, there is no redness. Anterior segment is normal. So, anterior segment means up to the posterior capsule of the lens. It's all normal. Great. Fundus examination shows chorioretinal folds. Now, chorioretinal folds, we don't know what it is. That makes life difficult. Anyway, let's proceed. Aage. No, don't discontinue, okay, this kind of questions. Don't say, okay, I'll come with the text round because chorioretinal folds dekha and you don't know what is chorioretinal folds. And look at, aage dekho. OCT shows subretinal fluid. OCT is the most sensitive investigation for subretinal fluid, and it has shown a subretinal fluid. Ocular ultrasound also we are doing. Okay, ocular ultrasound shows T sign. Oh wow, where do we get T sign? T sign in posterior scleritis. So I got the diagnosis. Posterior scleritis, you can get chorioretinal folds. See, when you have a compression from behind the eyeball, or some fluid, lot of things. So that kind of compression will cause the choroid and retina to be thrown into folds. Yeah. Okay, anyway, that is not the problem. What is the cause for her reduced vision? Diagnosis is posterior scleritis, but the question is, what is the cause for her reduced vision? Option A, posterior scleritis. Looks like the answer, no? But anyway, always when you feel answer is an option A, always read the subsequent options. Okay. Option B, serous retinal detachment. I've told you, it's there in the workbook. I made you write. The cause of decreased vision in posterior scleritis is serous retinal detachment. And you are asking me, ma'am, where is serous retinal detachment? Array, OCT mein you found subretinal fluid. That means it is serous retinal detachment, no? Serous retinal detachment, what is the hallmark? The subretinal fluid, the shifting fluid sign. Okay, that is when you are seeing the fundus examination. Subretinal fluid. The moment you have SRF, it is serous RD. Okay. Now, option C, subtenon fluid. See, subtenon fluid explains your T sign. But that is not the reason the patient is having decreased vision, right? So, it's not option A, it's not posterior scleritis, which is a cause for decreased vision. Because posterior scleritis to start with may not have decreased vision. Yeah? Okay. Option D, disc edema. Is there any mention of disc edema in the question? No. And thankfully, nobody has answered that. So, the answer to this question is, what is the cause for her reduced vision? Serous retinal detachment. So the chorioretinal fold finding on fundus examination has no bearing on the question that is actually asked, nor your eventual answer. Okay, so don't get scared by these kind of lengthy questions and all these funny words that are there for you. Don't get bogged down by all these jargon. Keep reading the question, keep reading the answers, and arrive at the answer with the existing knowledge that you have. Ruling out, elimination, common sense, and there you are, ophthalmology, all correct. Okay. Now this question gives you an image. So it has given you an image. So you can see fluorescein dye stained, and they say 10 seconds, and then you can see all these black islands, black spots. That means this is a tear breakup time. So initially you put fluorescein when it is confluent, and you're seeing the fluorescein dye under cobalt blue light, so it's giving you the greenish fluorescence. So it is a confluent, one single layer, and then it breaks up, because from the last blink, and ask the patient to blink, then tell him no, now don't blink for the next half a minute. Yeah, keep your timer on, count the seconds. The moment the first black spot you get, stop it. So in this patient, probably 10 seconds, that's what I've given. So what is the question actually? The image depicts Siedel's test. No, every live session I'm explaining to you what is Siedel's test. This is not Siedel's test. Jones test is you put the fluorescein dye and then you will do the syringing and all that. It's not this. Yes, and you look for the dye coming into the nose, not this. Yeah. Mebography is an infrared imaging where you look at you visualize the meibomian gland, the vertical meibomian gland, whether they are normal in number, they are normal in size, the length, their appearance, everything. That is mebography, okay? So not this. Tear breakup time, T-buts. And what is the normal T-buts? Tear breakup time, 10 seconds. If it is lesser than 10 seconds, indicative of dry eye. I'll take your question, guys, towards the end. Chalazion is one of the examiner's once upon a time favorite questions. Option A, acute suppurative inflammation of meibomian gland. That is hordeolum internum. Okay, acute suppurative inflammation of meibomian gland is hordeolum internum. And I put a beautiful image of that in today's Instagram. One of the posts today. Today you got a barrage of posts there. So one was a question, take a look at it. Acute suppurative inflammation of gland of Zeiss, that is hordeolum externum or stye, that is not chalazion. Chronic lipogranulomatous inflammation of meibomian gland, yes, that is what is chalazion. What is chalazion? It's chronic It's a lipogranulomatous inflammation involving your meibomian gland or your tarsal gland. Okay, the other name for meibomian gland is tarsal gland. So that's the answer. Option D, chronic suppurative inflammation of meibomian gland. There's nothing like that. Okay, at the moment meibomian gland something goes into chronicity, that suppurative, the pus component is gone. It becomes lipogranulomatous. Okay. Oh, all right. So we come to the end of the 10th question, and that is it. What are the question? Can you parcel what? I don't know. Whatever. Around the recti muscle. Kundan, what was it? It's always at 9 o'clock, Kundan. 9 p.m. we start sharp. That is quiz questions we discuss here. Yeah. Motaju, what are you talking? Nice to see you again. What is this? Dacryops. What do you want to know? Okay. Any other questions? Sorry, guys. Long day. ऐसे चलता है. What? Oh, you want me to explain dacryops? See, dacryops is in the see, you have many ducts of the lacrimal gland, no? See, you have a deeper orbital lobe and a superficial palpebral lobe. So from the deeper orbital lobe, you will have ducts coming to the superficial lobe and then the ultimate secretion. So in this ducts, if you have any small serous cyst, that is called dacryops. So that is more like you don't diagnose it clinically. Eventually you will see it on pathology. Yeah. See, the way we are solving MCQs every day, beta. See, the moment you see that, like today, watch this video again. Like that question on posterior scleritis. How did we solve it? It looked very difficult. First, you read and understand the question. Okay. Read the scenario, whether it is a one-liner question or it is like a paragraph type of question. You read the question thoroughly and gather the points that are given in the question, all the hints and the clues or the pertinent points, and after all that, still read the final question, what the examiner actually wants to know. Okay. Then you come to the options. You read each and every option. The moment you see option A as an answer, don't mark and move on, because sometimes you might have a better option down there. Yeah. And always go from known to unknown. Known to unknown should be the principle. You will know a lot of things, and there will be still an ocean of things we do not know. You do not know, I do not know. We should accept the fact. But we can always, go from the known to unknown. Meaning, with your known database, you have a lot of knowledge. Based on that, you eliminate options. You eliminate options not like, okay, I don't like option A. I don't like the look of option B. Not like that. Or because I don't like that topic. No, not that way. Common sense, apply a lot of common sense, apply all that knowledge, connect all the dots together and see if this is fitting or not fitting at all. Eliminate. Or you want to keep a dot in your mind and say, okay, I want to revisit this option, because probably it's an option A. You don't want to eliminate it. You want to revisit. Come back. Go to option B. Probably you can eliminate it. Then very many times when you eliminate it, you will arrive at the right answer. Most of the times. Or as you practice more MCQs, and you listen to more, every day you're watching 10 MCQs. See, at the end of 1 week, you already done 70 MCQs. And when I explain every question, I explain something more. So probably I'm explaining for every question 5 more MCQs. So imagine every day we're discussing close to 50 MCQs. 10 MCQs proper from the quiz and related to every question or every topic you all ask questions, or I myself am telling some 5 extra points. So we are doing some 50 MCQs per day. Okay, so 50 MCQs, and imagine at the end of a week, you're doing 350 MCQs. So when you keep on listening to this and you go back and, listen to this video again, no, I'm not saying watch it, listen to it. So the more you listen to it, it'll all be there in your mind, and when you go and sit for your test or your exam, it'll all come back. This is the knowledge that you gain, not only by your active learning, by this kind of passive learning. I mean, it's kind of active and passive in a way. Why I'm saying passive? Because you're listening to it. Why I'm saying active? Because you're engaging in that. I say you're bird watching and listening to this, then it will not register. Okay, so all this will come to play in your exam. So you connect all these dots. Yeah, you connect all these dots, then you'll be able to say okay, this option matches, this option is no way related to the question, or sometimes some fancy options like some I think today or yesterday we had some very fancy options. So the moment you see some fancy term, you feel like okay, that is the answer. May not be the answer, it'll be a very simple answer. Okay, so it just comes with practice again. So practice a lot of MCQs. Yeah, so who is that? Nas vibes. All right. Motojol, any patient with bilateral watering, what will be the diagnosis? See, bilateral watering, you'll have to do an extensive workup before you arrive at a diagnosis. It's not easy, okay? And for such a short live session, it's very difficult, Motojol. Okay, I discussed in the videos on the EyeMentor app, under the essays and short notes, the Epiphora workup. Watch that. It's there with the notes. But NPA and NPC is not today's topic, no? Why were you not there when we did refraction? How to manage trachoma? Please watch the trachoma video on the app. Today is not trachoma topic, and trachoma is such a simple topic, yeah. And already we did conjunctiva. What is this? You should also read, na? You should also take some effort, huh? So it is there. Trachoma I've explained completely, beautifully on the app. Watch the video. EyeMentor, download the EyeMentor app and watch the video there. It's under conjunctiva folder. Yeah, because trachoma is an important topic. It has been discussed very extensively. Any other questions related to today's topic? See, in the video description, I've given you how to download the app, because Google, it's very simple, EyeMentor Dr. Rajarathna. But on iOS, it's a little, we have a little devious or, very deviated way. Go through that and download the app. If you have any doubts, you ping me on the app anytime, 24/7. I'll always reply to you. Okay, any other questions regarding today's topics or today's questions as such? Okay, what is the topic for tomorrow's quiz? Every day is the same thing, no? Okay, I have to look up. What's the schedule? Guys, one of you tell me, no, what is the topic for tomorrow's quiz? Bacha, quiz will be at 6 p.m. on the app, on the Telegram group, and discussion will be here on YouTube at 9 p.m. Where is the schedule, man? कोई तो हेल्प करो यार. What is the schedule? अच्छा, tomorrow is investigations and instruments. Motajul, I think I already explained to you this previously. Okay, this topic I've already explained to you previously. कुंदन, अच्छा वही सोच रही थी ये कौन है कुंदन चौहान. बढ़िया, मुझे लग रहा था, बट सडनली आई थॉट कि कोई और भी होंगे कुंदन. बढ़िया है. हाउ आर यू कुंदन? वेरी नाइस. अच्छा, ऑप्टिक्स एंड रिफ्रैक्शन, चलो बढ़िया बना देते हैं. आई मेक. लवली टू सी यू कुंदन. कितने साल हो गए ना, ऑलमोस्ट 10 साल हो गए मिलके. तो अभी भी याद रहता है, आपका दिवाली मैसेजेस आते रहते हैं. चलो बढ़िया बना देते हैं. ये फाइन. ओके, okay, chalo guys, let me call it a day. Watch the videos. If you have any doubts, you ask me. कुंदन, कुछ भी कराना है तो मुझे व्हाट्सएप कर देना बेटा, मैं देखती हूँ. ठीक है, कहाँ कैसा करना है कर देते हैं. ऑलराइट, चलो बाय 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 बाय. सबको मेरा नमस्ते बोल देना. तो अभी भी वहीं पे हो क्या? चलो व्हाट्सएप में बात करते हैं. बाय.